OEBB-PEBB Work Group. On March the 19th, 2024, we are meeting virtually. And we have all four of the work group members present. Welcome back, Sean.
Yay, welcome
Thanks.
back,
Good to be here.
Sean.
Yeah, okay. So we like the continuity. So Sean, just for Robert's knowledge, how long you have been with the Innovation Work Group since its inception? Is that true?
That is true. Yes.
Okay, so he's a masochist for I'm kidding. He's been on for the long go. So he is in along obviously the staff, but Sean is our board member with the longest duration of being on. I think I joined Innovation Work Group in 20 or 21 or something like that. But Sean's been there since the beginning, which I think was 18 or 19, but
Yep,
time
fall of
flies
18.
when you're having fun. Yeah. Okay. So we've been welcomed. The first order of business is the approval of the synopsis from our last meeting. I'll accept any additions or corrections. Otherwise, I'll accept a motion to approve.
This is Kimberly. I'll make a motion to approve the minutes as presented.
Thank you, Kimberly. A second.
Second for me.
All in favor, say aye.
Aye.
Aye. I'll. Sure. I wasn't there.
That's great.
But I'm with you.
Yeah, I know.
Aye.
But Kimberly, yeah, thank you. So that passes. So let's just do a quick look at the agenda. Margaret is going to give us a 5-minute update on what's happening with the various work group updates. We're going to then be spending an hour or so on behavioral health standards, and we'll take a break, and then we'll review hospital utilization. We'll close with any public comment. So with that, Margaret, you're on first.
Great. Thanks so much, Tom. To kick things off, first of all, I wanted to just say welcome back. The work group has been taking a little bit of a break over the past couple months. I think our last meeting was in December at the tail end of last calendar year. As everyone I think is well aware, both boards have been really busy with benefit plan renewals for next benefit year, which have been taking a considerable amount of focus over the past couple of months, as well as we had a pretty busy short legislative session, which also took some of our attention in that direction. So I want to thank everyone for reconvening for this meeting as we get things back underway. One of the updates I think we've already acknowledged, I wanted to note Sean is back on the work group. So we are back at a place where we have 2 members from each of the boards, 2 OEB members with Tom and Robert's participation, and then 2 PEB board members with Sean and Kimberly. That to note, I want to note, and I think, Tom, we've had some conversation about this, that we will be expecting some additional evolution in work group membership as we get further into this year. Tom, I know your tenure on the OEB board will be wrapping in a couple of months. And so we will again be looking at a little bit more churn in the participation in this work group. But that said, I really appreciate everyone's robust participation and engagement. I think we're going to have a really good conversation today. Final update I wanted to share was just a reminder or a check-in on where things are with the Centers of Excellence work. This is a project that this work group has been looking at through various phases over the past couple of years. We shared some info at the last meeting. This slide you're seeing on the screen now likely looks pretty familiar. It's just kind of a recap of what we're looking at for the work plan for this calendar year at a very high level. I think as we noted previously, the first half of the year, Q1 and Q2, we're really doing some behind the scenes data work, reviewing the APAC data. Blue Book Health is partnering with Mercer to do some of the quality measures analysis. And we're looking at the second half of the year, third and fourth quarter, to really get into having some data to share, getting into being able to kind of take a look at the metrics and scoring methodology associated with those metrics for facilities, and also work to sort of reestimate the opportunity gap based on the updated data. So all of this is just kind of to note in this update that we are still on track with this general timeline and expect that as we get into the second half of the year, we'll have more substantive information to share. Any questions about that?
Sounds great.
Great. All right. That, I think, covers it for all of the updates I had to share specifically. We can move on then to our next agenda topic, which is the
And
behavior.
I'm going to have Damien make sure that we at the OEBB leadership, we talk about additional IWG participation. We should start that
Don't
process.
pull his tongue.
Of course,
What?
we'll do that.
Great, thank you. Okay. All righty.
Great.
On to behavioral health.
Yeah, thanks, Tom. And so Mercer is going to be diving into this presentation. Before they do get started, I just wanted to give kind of a high-level overview so that you know sort of what we're here to have an overall sense of what we're here to ask the work group for today. So as you likely recall, we do have a collection of performance guarantees in all of our medical plan contracts. One of those guarantees involves our health plans putting 5% of their administrative fees at risk for plan administrative measures. These are measures that really look at plan operations, things such as claims processing timeliness, claims accuracy, speed to answer, those types of operational and administrative measures for the carriers. And over the course of working on our contracting, I think as staff, we've sort of identified that in general, performance on those administrative measures is where we would want it to be. And that there may be some opportunity to shift that 5% of administrative fees at risk to a different focus area for PEBB and OEBB, an area where we really want to try to drive some improvement in the care and services provided to members. And so with that said, as background, behavioral health is a high priority area that's been identified by both of the boards. And so we're coming to you today with a high level proposal for shifting that 5% of carrier fees at risk for the administrative measures into measures that look at behavioral health networks and access. So that is sort of the background context. I will go ahead and hand it over to Christy to sort of get started with the slides. And I think as we move through this, we're certainly open to taking questions along the way, or, you know, and also we'll have some time for sort of more in-depth discussion at the end.
I think Emery's gonna kick us off here, and then I'll jump in.
Okay, thank you, Christy.
I had a quick question just as we get started. I've read through this section. Have we solicited any feedback yet from our 3 health plans, Providence, MODA, and KP?
Yes,
that's just something we're going to do after we go through this initial.
No, Tom, we actually have sent over essentially the network standards and performance guarantee elements that we've listed in this document, and we have heard back. I think there's and we'll go through some of it, but
if you can feed that, if you can just fold that feedback into the presentation, I think that'd be very helpful.
Yeah, And we can definitely do that. And actually, part of it was to kind of like kick off this first slide, and Margaret
Okay.
has actually covered a lot of this topic in terms of the performance guarantees. And with OEB, there was the discussion about, and actually with PEB as well, and part of IWG historically, to create these network standards. And so we talked about what are best practices, what we've seen out from other clients, other entities, including Medicaid, and what CMS is going to require, and what we currently see for OEB and PEB in terms of network standards, and also the kind of performance that we want to see, and the kind of enhancements to behavioral health networks that we would want to see. And we created some standards, and as mentioned, there is like using some of those best practices standards. And Christy can kind of go over those in just a sec. But taking those into creating these standards, and we did send them over to the carriers. I think we definitely heard some pushback on some of the standards. Some of this is new, and we are asking for essentially advancement. But we are also asking in many ways on some standards that are going to be, or will be, or have been implemented by CMS, and we'll talk about it on the next slide. And essentially, we're trying to transfer some of those over into the PEB and the OEB plan. And so we do want to push the plans forward and make things, behavioral health has been, especially for PEB members, and since I'm the actuary in PEB, we're talking about some of the cost drivers. Outpatient behavioral health services have increased dramatically. It's like almost a percent of the overall cost increase per year over the last 5 years has been because of behavioral health. There's needs. COVID has exacerbated those needs, and we're trying to ensure that we meet the needs of the members by creating these goals and these performance guarantees. And yes, we are pushing, but we also have had standards, or we know that there are best practice standards out there. And Christy, is there anything that you wanted to add about some of the standards that we took from to help craft these?
Yeah, I could just say, so again, we did, look at Oregon's Medicaid. There's also in January of 2024, a ruling of the network standards that we've incorporated here. And then also looking at commercial plans across Mercer's book of business for a lot of the clients that our behavioral health team supports, looking at the performance guarantees and standards that are in place there. So I really looked at a wide breadth of information and kind of pulled it all in together, picking the best, again, in an effort to kind of push in order to ensure that we're having the best behavioral health access that we can for OEB and PEB members.
Yeah, thanks. And, we did ask and sent over information to the carriers to see if they can report and measure some of these standards. And there was some concern about some plans were not able to, or some plans would actually have to go out and hire people to do so. And in some cases, yes, we understand that. Some of these reporting, especially the secret shopper, and we can actually move on to the next slide. Some of the secret shopper comments, I don't know if you've listened to like when Dan presented some behavioral health standards and some ways to measure network access. One of the ones that really got people's attention is really having a calling these providers and seeing whether there's actually appointments. And that's what CMS is doing. So they're finalizing new regulations essentially to ensure that first bullet, which is alignment, which is the 90% compliance with maximum routine appointment wait times. So basically, these companies, these firms, would go and call member providers, and it's a subset of the providers. It's not every single provider, and we do kind of incorporate that in some of the performance guarantees later, but calling them just to see whether you can get an appointment within this amount of time. Because you can say you have a provider, but unless they actually have an appointment, what value is that provider? And this sort of reporting does take time, take money, but it is going to be a requirement for Medicaid. And we want, it is an example of a best practice standard. And we've seen reports when we've done some audits of the plans, at least for PEB, where they've looked at the access and whether you could get an appointment time. And that kind of reporting, I think, has been invaluable in terms of actually looking at how good the network is. And so those are sort of the things that we're trying to push, trying to suggest as a network standard for PEB and OEB overall. And so some of those standards are there, as well as some of the requirements of, and I think these are things that we've talked about for other providers, but talking about for behavioral health in particular, the provider's cultural linguistic capabilities, and whether they, noting whether they have accommodations for, physical disabilities, in terms of access and, exam rooms and other things for people who might be differently abled. So these are, maybe things that haven't been reported on consistently or historically, but they will be required, at least for Medicaid and, potentially, hopefully for PEB and OEB as well. Chrissy, was there anything that you might want to add on this?
No, I think you covered it great.
Okay. Yeah. And so before we turn into the actual standards, I didn't know, just want to open up to see if there's any questions or comments before we actually get into the details.
As when Medicaid has these as standards, what's the implication to a health plan if they don't meet that standard? Is that clear yet?
I do not know for sure, actually. Maya, are you on? Do you know for sure?
We don't have to answer that now, but it's just that it would be if there's significant monetary complications or not meeting standards, it'll be pretty easy to follow along.
Yeah.
Because
and
the health plans will be forced to.
Yeah, definitely. But yeah, it's kind of, it's like some of the feedback we heard, it's like, we don't do this right now. It's like, yes, understood. But it's going to be required in the future. And most, all three plans work with Medicaid programs in some way or another. So it's not going to be completely unknown in this case. Okay, so with that, I'll turn it over to Christy and we can move on to the next slide.
Great. Thanks, Emery. And so, so as I shared, we've really compiled from a variety of resources and just these best practice standards. And so I just want to open with going back to saying, Tom, your words resonate with me. And I know in the past when we've talked about this, it was really making sure that there were meaningful standards in place. And there's a lot of different components to that, I think, and recognizing that it's not just, it is having kind of a multifactorial approach to this, because just knowing how many providers are in the network is not enough if they don't have appointments available or they don't have capacity. So, I wanted to start with kind of some in-person appointment standards. And so this is where that kind of an access survey or the secret shopper component comes into play. And so, having some of these standards. So the first one, right, is that, knowing that about 75% of the providers that are paneled are accepting new patients. Again, they're really important. We've heard of ghost networks and we've heard of, we have, 10,000 providers in our network, but if those providers aren't taking patients, then they're not going to be good, a good resource for obviously PEB and OEB members. Nextly, we see a lot in the standards, kind of this breakdown of acuity of care and how quickly somebody needs to get in to see an appointment. And so you can see here that kind of this care for emergent, so not life-threatening, but emergent, having appointments available within 6 hours. Urgent behavioral health. And so this is having an urgent need, not routine care, but a higher level of acuity and having an appointment available within 24 hours. This standard here and the next one, I just wanted to point out, are part of this OHA network standards rule that was announced January 22nd of 2024. So these align with that. Next, we have kind of this routine behavioral health initial appointment. So oftentimes if somebody's had the courage to reach out and to try and schedule appointment, it's best practice to try to get them into that initial appointment, getting them assessed, and having that treatment plan being written and starting to put into play. And so having that initial that initial appointment is important to have within 7 days. And then routine behavioral health ongoing follow-up appointments, more flexibility there. And what we're typically seeing with best practice standards is that 90% of offices have these routine ongoing appointments available within 14 days. Some ideas of the metrics there that you can see that could be reported again would be through these access surveys, making sure that we're having a representative sample size of prescribers and of master's level clinicians. And that could be LCSW, so licensed clinical social worker. It could also be a licensed professional counselor. There's also licensed marriage and family therapists. So recognizing there's a couple different types of licensures that fall within that group as well. And making sure, again, that we want to have a good representative sample of the offices or the providers in the network that are being called in this kind of secret shopper. The thoughts are to create a baseline in 2024, and then really starting to measure from there, talking about, meeting the standard. Is there improvement towards the standard? Again, really trying to just push on making some progress.
Yeah.
My only
Go ahead.
comment was on non-life-threatening emergent versus urgent. I'm not sure how easy that is to differentiate. Also, having a requirement that offices have appointments available at within 6 hours. If the person's crisis started at 9 p.m. on Saturday evening, that would require a whole lot more definition. I don't think we would be expecting offices hearing that phone call at 9 o'clock on Saturday evening to be seeing the patient at 2 a.m. on Sunday morning. But that's what would have to happen to meet the rule as you've defined it. So I think that's an area that that's the one that when I looked at this that jumped out at me and saying, boy, I'm not sure about that. I don't know what it means, and two, how an office would implement that. And the same issues like around appointments within 24 hours. If the issue came up on Friday at 10 p.m., does that mean that the expectation is an appointment would be available at 9 p.m. on Saturday? We're going to need to think through some of these, at least to understand more than just a bullet point. And I'm sure there's more information behind all this, Christy, but it's all going in the right direction. We need to be pretty clear when we talk about these.
Yeah, thanks, Tom. I appreciate that. And I do. I think the practicality of it and operationalizing it, it requires further discussion. And, I kind of look at the emergent piece is that if somebody calls their primary care provider at 9 a.m. in the morning and they're, can they get a same day appointment? Can they get in and see somebody who is at least going to help them navigate and triage what's going on so that they can get the care that they need that day for that emergent need? And then urgent, 24 hours, I guess, could be considered next day. So again, I think, yes, more to kind of dive into here as we try to operationalize it and talk about how it, is reality with provider offices. And maybe it's having caveats around that this is during, Monday through Friday or something like that. So more details.
Exactly. Sean?
So my question's a little bit broader, but has implications on these measurements. And so it's probably something just to put a pin in later. My question is, I guess lately I've been thinking about behavioral health access broader than what what we mean right now in this document and measurement. I think typically when we're talking about behavioral health, as far as I understand it, behavioral health access, what we mean is talk therapy. Generally, we mean like a psychologist or a psychiatrist, or we mean, you go in their office, you sit and it's talk therapy of various types. And in the medical side of things, on PEB, there's alternative medicines that we've kind of allowed space for. There's acupuncture, there's this sort of thing. Well, there's an equivalent side here of behavioral health that works for a lot of people. Let me give an example. During the pandemic, there was obviously like a lot of stress in Oregon Health Authority, right? Because a lot was happening. And so like there was this group that was brought in that was like behavioral health. It was like a behavioral health mixed team. And they had lots of different types of people. They were psychiatrists, they were psychologists. And their specialty was that their usual background was they worked with emergency responders, people who are exposed to trauma. And and part of that team were chaplains. And that sort of like guidance, which isn't going to be appropriate for everyone, but for some people it's appropriate. And so I'm just kind of like opening up as I guess a question is like, is anywhere in the sort of nation, is there discussion of like a broader definition of behavior that includes some kind of alternative items such as that, just to broaden, just to deepen the bench, basically, that some people may find appropriate for them, such as like somatic, like breath work or like chaplain or something like that. And some of those things actually do have some credentials within their own field, kind of like acupuncture or whatever. And I'm a bit sidestepping the whole issue of like evidence-based medicine, because it's like, how do you prove, whatever. But I guess I'm just opening it as a topic. That, first of all, that is not what we mean, because we have very specific definitions that I think are on the next slide. It was like, this is literally what we mean. And then like, is that even a thing? Like, does anyone ever cover anything like that? Or is that just totally insane from the point of view of like coverage? Do you know what I mean? So yeah, just throwing that out there.
We can explore it.
Yeah, and so Sean, it's not insane, and I have seen it. I've seen
Well, that's good.
many.
I feel better.
Yeah,
about
so
that.
and I will say also, my daughter is currently studying to be a somatic therapist with recreation therapy as well. So anyways, it's near and dear to my heart. And so typically organizations, I would say, depending on, right, and you mentioned like first responders, where I've seen this most is in healthcare. And so within healthcare, a lot of times, especially in my experience working with a faith-based hospital, they had actually an internal EAP, they had chaplains, and we also had a peer support group that was from Johns Hopkins that we also integrated into our healthcare system. And so there was a collaborative approach, and we all worked together. There was well-being, there was EAP, there was peer, and then there were chaplains. And we all coordinated together to meet the needs of that workforce, and doing individual therapy, doing group. As you said, talk therapy doesn't work for everybody. It works for a lot of people. but it's not for everybody. And so I agree. I think further topic, what other modalities are covered by the health plan? What other options are available? There are, there are lots of experimental things happening right now in behavioral health.
Right, especially in Oregon.
And especially in Oregon and Colorado.
In Colorado.
Where I am, we have lots happening here in Colorado. So, there are some additional things. So definitely a great
I appreciate
topic.
that. Yeah, maybe we just
Mhm.
put a pin in that and it
Yep.
for discussion, because
We'll explore.
as far as like taking
Mhm.
pressure off of the system,
Yep.
especially like in Portland, I bet if you polled our members in Portland, I bet you'd get something like 30% would be interested uh in one of those alternative therapies.
Yep.
In addition or instead
Yep.
of talk therapy, which would be a huge like pressure release if we could figure it out. So anyway, there you go.
We're,
Yeah,
we're
I
down
guess
to about 30 minutes. So
awesome. Okay. The only thing I want to add is I do think some evidence-based care is important to make sure that, there is, because there can be lots of other things out there. So I think, but there are some really good evidence-based care approaches that are outside of talk therapy.
Yeah, and one quick thing before we move on. So Tom, in terms of feedback, we did hear a little bit pushback on creating a baseline in 24 versus creating a baseline in 25. Figured, we want to know earlier. So, that's our recommendation to go
I agree.
24.
I get it. Yeah.
All right. So if I move to the next slide, please. All right, and so then the next standards that we wanted to just bring forward was for virtual appointments. And so this is specifically with a partner that the carrier might have in place. And so virtual only. This is not for saying a provider that's in the behavioral health network that might offer virtual appointments in addition to in-person. So this is strictly for like a third-party partnership that is a virtual only provider. An example of this is like Spring Health or a talk space, something like that. So median time to first available appointment, 3 days or less. We're seeing this across the board as a strong performance guarantee with these types of vendors. Median time to first available appointment for medication management. Now, I will say some of these vendors actually don't differentiate between a therapy appointment and a medication management appointment as far as putting their fees at risk at that 3 days. But I have also seen a lot that it's a little bit harder to get in to see a provider for medication management. So that one would be at 5 days or less. And then matching with a provider. So oftentimes these virtual only partners have a great digital front door. So somebody can come in and I'm most familiar with Spring Health, but a member comes in, they do a clinically validated assessment that is smart in how it assesses that person, moving through it very quickly, really getting to what that member needs and what the acuity level of their care is. They can also then pick provider preferences. And so we're seeing that, within their performance guarantees that they're offering, 90% of members are recommended a provider match immediately through the platform. Or if they have a higher need, or maybe they have multiple preferences that they really would like to have met, then a lot of times if they are interacting with their care coordinator, then it's within 1 business day that they get that match. Any questions on these? All right, moving to the next slide, please. All right, so some network provider standards. So this is the provider to member ratio. This is in-person and virtual providers combined. And this is for the carrier's full population. So not just for OEB and PEB, but asking for a report that would show that for all the lives they cover, do they meet these ratios? And so these proposed standards, again, and going back to kind of where we compiled these from, we do have, Medicaid does have also some of these ratios in place. So I just wanted to also call that out. But you can see here, prescriber. This is one area. So right now we have this described as psychiatrist. In some of the standards, though, I'll just point out that there's variability on who is described as a prescriber. In some of the standards, this could actually be a PCP, it could be a DO. So there's some variability there. In this level here, we're just saying this is a psychiatrist. In my experience of working in a primary care office, primary care providers are amazing. However, they're expected to know so much that oftentimes higher acuity needs, it's harder for a PCP to know exactly how to prescribe. I worked in a clinic where we did have actually a psychiatrist that came in one day a week and did consults with our PCPs. But anyway, so that's why we've kind of called out there that this is a psychiatrist. Master's level clinician. Again, we've kind of shown here what those licensures would be that would fall under that. A psychologist. Typically, psychologists do more of an assessment. And then we have some of the facility level kind of standards here. And then recognizing, again, for the full population, there are less standards with the facility level to pull from and to compare from. So any questions on these?
Yeah, I had a comment on them.
Mm-hmm.
I think that these standards are that are not relevant without understanding the environment. So if there are 10 health plans that share, each have 10% of a population versus a closed, then the comparison would be for one place that had 100% of the population in their plan, and they have the same ratios. So it's like, what's the expectation for Providence and MODA, where they're sharing amongst all the other plans, and a Kaiser Permanente where 100% of the master's level clinicians they have are devoted to their population. So that part is the ratio part is does not apply to context of what the population is. And so in some situations, I'm not done. And then the other part is around facilities. Health plans don't control the development of facilities. So, I can understand these as recommendations. I'd never support these, what you have written down here, as some performance guarantee, because this is, again, the first part of it doesn't deal with populational relevance. And the second part, these aren't the levers that the health plan have to offer. So those are my comments on this.
So I guess I'm going to push back a little bit, because the health plan needs to consider the health plan, some of these are from CMS or Medicaid, and the health plan needs to consider the needs of their population. And it's also in conjunction with the availability, right? It's like, if, you may have a provider, but if they're not available, then what's the use of that provider? And so I don't think you can take this just on its own. It has to be done in conjunction with, actually, can you have that member? And if they have a certain number, and they to service the population they have. And we break it down further in the next slide, where we actually start taking a look at various counties and the time and distance, because getting to those providers is difficult. And so
Emery, what you just said is, I believe, is exactly right. What matters is whether or not there's availability in appointments. So the previous slide is where the issue is. The number, setting a standard saying it should be 1 per 1,000 is maybe grossly overstated, grossly understated, depending upon that particular environment in terms of number of plans and the number. So this one, I think, is you could have all of these in place and still have have inadequate availability. Or you could be putting a situation where acute behavioral inpatient facilities per member. How is MODA, for example, going to influence the creation of behavioral health inpatient facilities? That has been a challenge in the state for the 45 years that I've been here.
Yes, but it's not that they have to be. I mean, it'd be preferable to be in state, but it doesn't have to be. And I think MODA.
Okay, so then they go out and contract with a behavioral facility in Iowa, so that they meet the criteria.
Well,
that's helpful.
Well, I mean, MODA uses Betty Ford, and Betty Ford, isn't. I don't know if there's one facility in the Oregon, but I mean, it's what LA is. I think is the most famous.
I've expressed my concern about it, and
okay.
There may be others of concern, but this is one that's going to require a lot of work.
Well,
if I was voting on this, I would X this whole page.
Okay, but I'm going to say page 2 or page 4. What the first one with the availability does not mean anything if you only have one provider for every member that you have. For one provider to service every member, and that provider's accepting new patients. I don't think that's helpful. It's probably not likely, but that's the way it could be.
We need to be able to have a measure that looks at our membership and see whether or not they're getting in to see the right level of care in the right amount of time. That's all. We're all in 100% agreement with that. So let's figure out what the measurement is. And I'm also, you started off the presentation saying, that OHA, CMS is making requirements. So far, of the about 12 of these measures I've seen identified, I've seen 2 that someone has said these are measures that that CMS is going to require. We need to be very clear. I think the IWG needs to be very clear which of the measures are being proposed here are Mercer's recommendation versus what they're going to be required to do through CMS. And I don't have that clarity yet.
Tom, thank you. I appreciate that, because I guess again, it's when I looked at this, it was really pulling from best practices across, it was CMS and Medicaid. It was also commercial plans and what we're seeing with other really large organizations that we're supporting. And so I was trying to bring in, I guess, some of that insight to what we're seeing. And I also, I guess I'm wondering with some of the facility kind of numbers, I do think it is the responsibility of the plans to make sure that there is a care option available for somebody who, let's say, has an eating disorder and needs that treatment. And so what I'm hearing you say is, maybe having this ratio isn't the right way to measure it, and maybe we need to come up with a better way. But I think in reality, what we're trying to get out is making sure that these service levels are available for people that have these higher acuity needs, and especially for substance use disorder, that there is enough of these inpatient facilities or even IOP programs. Because what happens if that's not available, these boutique out-of-network facilities are reaching people and they are getting them. We're seeing them actually, they will offer to fly people to their clinics to get them in, into their facility. So I
Got
think
it.
it's just,
Understand that.
yeah. So I
we
think,
need to meet to understand, have
yeah,
access, have standards that
yeah,
look at have our health plans show how well or how not well the people they're responsible for are getting in to get the services that they need. And there's a geography associated with that, and there is a so the
yeah,
ratios are one way of getting to it, but it's kind of it's not it's a shadow on the wall as compared to the real object.
yeah. I appreciate that. So we can work more with carriers and see, again,
Super.
what we can come up with. Okay.
Yeah.
Moving on
Thank
to
you.
the next slide, of course. Okay, so time and distance standards. This is for in person, and this is very specific, exactly what the OHA network standards are, with a few call outs here. The items that have the asterisks, which is the psychologist and the ABA providers, and then again, the facilities, those 3 items are not specifically called out in the OHA network standards. So starting at the top, what the OHA standards did also say is that they're doing these county designations. So large, urban, rural, and then CEAC is that counties with extreme access considerations. Again, you can see there's those master level clinicians that I've described what those are, child and adolescent clinician, and then medicated assisted treatment providers, which is for substance use. It was interesting in the OHA standards, I will say that a MAT provider is not called out specifically, but substance use disorder treatment is a tier 1, which is what those top 3 pieces are, is it's a tier 1 service. And so that's what designates that first line item there for those top 3 items there. So large urban would be that 10 minutes, 5 miles. Urban, 25 minutes, 15 miles. Rural, 30 minutes. And then the CEAC, that 40 minutes. The typical kind of performance guarantee we see around this is that 90% of the members must have at least one practitioner accepting new patients. That's kind of our ad, right? Because I guess it's important for these providers to be accepting new patients. Otherwise, it doesn't do them any good if there's one provider within the time and distance standards. And then the lower options here, as I called out, so psychiatrist is in the OHA network standards. That is also, it's considered a tier 2, which is the difference of the time and distance standard there. And then, as I said, those other 3 there are not necessarily specifically called out by those types of licensures or what they offer or the facilities. But in general, the standards show that mental health is definitely a tier 1 or a tier 2. So we put those in the tier 2 standard timeframes. Any questions, feedback? All right, I'll move to the next slide. All right. Network provider diversity. So we know this is such an important component for PEBB and OEBB. And really our goal here is to make progress in the diversity of the behavioral health provider network. I believe right now, to the best of my knowledge, that the providers in the network are self-reporting. I think for all of the carriers, basically their race, ethnicity, language. And we have varying reports of what that percentage of self-reporting is. I do think it tends to be a little bit higher with the behavioral health network providers. The other thing that we have on here is some office accessibility and then clinical specialty. Some of these standards are a little bit harder to get at. And just one example I'll say is as far as like clinical specialty or cultural competency, or I actually like to use the word cultural humility, is that it is really important to know what is that metric? How is that provider, if they say, yep, I'm culturally competent, or I meet the needs of this population. I think it is important to know to have some sort of reporting on what that means. Is that an annual type of training? Is it done by years of experience? Something like that, because it does tend to be sort of a check the box. Yep, I'm culturally competent. And that a lot of times also is self-reported. So having some more information there. The other thing that I think we had talked about also was office accessibility and what that means. And I'm sorry, Emery, I think we had with that CMS information that they had maybe dialed down a little bit more to what that kind of accessibility standard means, or but it's another important component so that people are able to access and get to the provider's office and have it feel comfortable and approachable for them. So I think more to come on this. And, I think really, again, we really would like to create a baseline, know where each of the carriers are at, and then be able to measure and have some improvements in future years.
Yeah, and to the culturally and linguistically sensitives, being sensitive. While OHA, as part of their directed payments for Medicaid, they did, instruct plans to pay more for those who have the CLSS designation. But getting that designation is difficult. So, it's like, while we would want to have something along those lines of that designation, but it's just really kind of improving and creating something potentially to help make sure that you have providers who have that training and knowing. So if you're especially in need of those, that designation, or at least like an indication that the provider has some training and ability to service that is helpful. It's definitely a key. I think, it's a question that's like I ask of when talking to new vendors, but it's putting it in as a requirement, and to like measure to see who has designated and who might, and to see improvements, I think is definitely important for the future for OEBB-PEBB. Christy, is there anything else on this slide?
I think that's my last slide. I think that's it.
Okay.
Mhm.
All right. So
go ahead. Can I have a comment?
Mhm.
The problem that we're going to have, I agree that it'd be great for our health plans to be able to require, I think, and this is Emery's point, that all of their behavioral health providers do this reporting, to be able to define what what they're like, to be able to help patients know what they're getting. The catch, of course, is particularly in environments where there aren't many therapists. If that became a requirement, would we be losing, therapeutic options? And so I don't know whether or not, how we deal with that conundrum of potentially losing some therapists who are saying, "Hey, I'm not going to fill that form out," and yet how important it is for patients / clients to be able to have that information as they're looking for providers to help them with their particular concerns. And I don't know if that's ever been kind of worked through.
Go ahead, Emily.
No, go.
I was just going to say, what I'm seeing, there are definitely some vendors that I would say are, it's kind of like sharing with your provider network the value and why behind asking that question, and recognizing too that credentialing typically happens every 3 years, right? So it can be kind of a lag process of getting that, unless there is a concerted effort. And again, it takes communication of why are we collecting this information and providing that value to providers, because we are seeing that some vendors that are doing like behavioral health carve out are able to capture that information. They're even, they have provider pictures. I met with a carve out that is doing videos of their network providers, and they've had really great uptick from their providers being interested in that. So I think it's a big, I understand it's a big lift to do those, but I think it's important, and having it required, I think, would be key. And I think there's a couple things. The only thing I have heard about with providers is providing gender identity and sexual orientation is not necessarily something that they want to self-disclose, but other demographics it seems like they've been feeling more comfortable reporting those.
Okay.
Yeah. And I think there was a story with PEBB, and Sean knows this one pretty well, where, hopefully it could have been avoided, and it was a pretty bad situation without having some of this information available. And it just, it does, I think, to me personally, I think it would do much more harm than it does a ton of harm in a situation where it could have been avoided, hopefully. And yeah, so I and there are definitely a lot more firms out there, a lot, when we're talking with Moda to Chrissy's point about like having videos or pictures of people, the Teledoc, when Moda was talking about the 360, and these are sorts of things that Teledoc is putting up on their website, or when you're selecting a provider, so that you are able to identify this. And some people may not want to provide that, and in some ways that gives you some information as to whether you might want to see them or not in that case. But it's just.
And Emery, I'm sorry, I have one more thing to add too. I just want to say, like, Psychology Today, which is just a public resource site that somebody can look. Unfortunately, a lot of times what happens is if you're trying to connect somebody to care, and we did this in our primary care offices, is we would actually pull up Psychology Today where we could see the picture of the provider, and then we would go searching and help the patient find a provider in their network and cross-reference so they could actually see it, because a lot of times that's what they want in order to feel comfortable getting connected. So anything we could do to make that connection come back together better would be beneficial for members to get the care they need and to really solidify that therapeutic relationship, which we know is really the number one component to therapy actually having a clinically successful outcome.
Thank you. There are no other comments on the provider diversity. Let's move on to the next slide. So while these are not necessarily like taking the administrative performance guarantees and then changing them potentially, or specific behavioral health standards, we just kind of wanted to bring in some information about the current clinical metrics that are part of the performance guarantees. And Margaret, please feel free to correct me if I misstate anything, but some of the current metrics that actually the plans are include as part of the guarantees are listed there at the top. There are 2 other HEDIS metrics that are on the approved list, which are listed down there below. Substance use disorder for follow-ups after high intensity care or emergency departments. And that's the standard for that is 7 days. The metrics for the 2 at the top, they could be revised to be 7 days, which is obviously a stricter standard versus the 30 days, but these are possible revisions to those clinical performance guarantees, and just wanted to mention that. Christy or Margaret, is there anything that you wanted to add?
Yeah, I'll just note, I mean, you're right, Emery. We do track some of the HEDIS measure around follow-up after hospitalization currently as part of our clinical measures. And just to note, in some instances for carriers, when it comes to PEBB and OEBB specific rates, they don't necessarily always have a HEDIS statistically significant denominator size to report a PEBB OEBB specific rate. So in some instances, depending on the measure, depending on the carrier and their enrollment levels, we may be looking more at commercial book rates, just in order to have a population size in the denominator that would reach that HEDIS NCQA identified level of statistical significance. So I think these are additional clinical measures we're looking at. And I think there's some potential there, but the specifics around exactly how we would track would need to factor in those concerns around denominator size.
And changing the making the standard, moving the standard away from HEDIS also keeps us from being able, at least our current methodology for the clinical performance guarantees has to do with relationship to HEDIS measurement. So if we customize something, it may be the appropriate thing to do. The problem is then we lose our national comparison. So we're stuck there too.
Yeah, certainly duly noted. I mean, we would need a really, really good reason to want to deviate from in a case like this, when we're talking these type of measures from the nationally validated benchmarkable approach. I don't think we would recommend that. So yeah, that is a very, very good point to note.
I'll have to double check them. I thought the top two with 7 days would be HEDIS. These are all HEDIS metrics, but I'll have to double check that.
Yeah, my understanding is these are, yes.
Yeah,
They are.
Okay, so we would then, at least in terms of the process, I would think that CIAL would be the place to where we would approach debating clinical performance guarantees. I think absolutely appropriate for IWG to take on this change in regards to administrative fees, where we're looking at not the what's in when we're looking at the access component and the network component for behavioral health. I think that's appropriate for that. What we're talking about, moving away from strict administrative to using it for behavioral health.
Yeah, certainly. Yeah, HEDIS does, or CIAO generally is the forum where we annually review the clinical quality measures guarantees, and also just want to note that I think we would also consider that oftentimes when we're looking at tracking a new measure, we look at the initial year potentially as a report only year, sort of to get that initial baseline. So I think that's also part of this. I just want to note is sort of part of this whole discussion.
Yep. Yeah, and these are just the comments. I mean, yes, CIAL would be the appropriate place to do this, but just wanted to note potential additions to the HEDIS metrics that are available. Okay, so the next slide probably had the most pushback because these were the actual potential penalties, financial penalties. These were our recommendations, where we would start doing 24 to create baselines. And it's just kind of a reallocation of that 5%. And these are suggestions. Obviously, it's negotiations and discussion, but just kind of talking about some of these standards in terms of in-person access standards. Yeah, that does require new reporting. That's additional funding, new funds, or there's going to be a need to pay for that reporting to hire that third party. So but getting that report in 24 to kind of create the baseline, see where we are. No penalties per se potentially in 25, but seeing where we are in 25, hopefully there's improvement, and in 26 really getting into that penalty. So that's potential penalty if they aren't improving towards the standard. So that was one of the requirements. This virtual access standard, as most of these providers are essentially third-party vendors, like Spring Health, it would be potentially required for new third-party vendors. So it's basically a minimum requirement for PEB and OEB if a plan were to go out and contract with a virtual-only behavioral health provider. And so, as Christy mentioned, these standards were created based on what we've seen in the marketplace, and a lot of the new, if not all of the new vendors are meeting that. That should not be an issue. And so just making sure that the standards are met in 25 and then 26, because if it's either required or it's already in, if they're not, willfully not meeting that standard at that point, even if we talk about in 25, then maybe having penalties applied at that point. But that's a couple of our recommendations. With the network provider, in terms of that 1 per 1,000, we did put some penalties to that, and we'll have some discussions around it, especially, and also we would split it between that overall for the entire population by the counties for the access. The provider diversity, penalties went really, I guess we would say, do not apply penalties until 26. 25, we would want reporting and make sure they comply. So no penalties unless they don't comply. And then 26, we would want to see some sort of improvement towards the standards. And then HEDIS, again, part of the clinical PGs. So these were some of our recommendations, and there was definitely pushback as to, we don't want to put penalties against something that we aren't reporting on, but will be required to report on later for CMS, but as well as some of these network provider standards. In terms of where Mercer's thinking, there could be some good penalties or good standards to be met. This is at least our initial look at how we would allocate it, and would definitely welcome comments and questions from the IWG.
Okay, so let's have committee members, work group members comment what their thoughts are.
Well, I can start. For me, since I'm new to this, this has been really educational to me. I didn't come in with, a preset questions, and I really appreciate Tom's feedback on that, because that really, opened up my mind to what I was actually looking at. So I can't really say I have anything to add, at this point in my new IWG venture, but I really appreciate the discussion.
Okay, Robert, thank you. Kimberly?
Well, I mean, I like the direction we're going in. And one of the things that really hit me was when Emery said, we definitely want to be careful when you tell somebody that a metric is absolute. And then if we do nothing with the data, we need to make sure that what we settle on is something that we're actually going to use that helps move PEB and OEB forward. Is kind of, I almost felt like those were words of caution whenever we're looking at any of these things that we all of a sudden, or not all of a sudden, we've worked a long time on this, but the stuff that we start to make required, or, part of their fees at risk. And I just, that's the piece that really educating ourselves on what we'll use, not just what we can hold people accountable for, or what really is the best for the patients is always the piece that I'm looking at, is what's the best for our employees and what helps them. The numbers before, where we were talking about 1 for, I was just looking at those numbers going, there is no way. That's why no doctors have room, because those statistics are scary when somebody's in crisis. So,
yeah. Sean?
Yeah, my very first introduction to the CL was so long, years ago, back when y'all were still meeting in the old PEB building. Do you remember that?
Yeah.
In that building? I'm pretty sure you were there, Tom. I might be wrong, but I'm pretty sure.
I've been around for 8 years.
You're referring to the dungeon, huh?
Yeah. And the meeting was on behavioral health, and there that was the topic, and I was a guest. I was just there to listen, and I think the guy's name was Marshall, and he was there. He was talking about behavioral health access, and particularly substance use disorder access. And the statistics were horrifying, of course. And that was a long time ago. And as far as I can tell, we haven't made a lot of improvements since then. So my point is, this is not new. This is not like, oh wow, now PEB and OEB care about behavioral health. Like, where's this coming from? So, so I think having, like, talking about, like, I understand they want to delay, but talking about having some expectations with some actual grit in it in the relatively near future seems appropriate to me, because it really isn't new. Like, this is a long time coming. So I support the idea of having the some kind of standards such as this on some sort of timeline that's reasonable, such as this. Now, negotiating some of the exact minutia, with exactly how you measure it and this and that, fine. We want it to be, of course, we want it to be as close as possible to being actually effective to what we really want, which is access. I don't really want the fees. I want them to improve. But over the years, we've tried just being like, hey, this is a problem, please deal with it, and to know, with limited results. So I think I support this idea of having these guarantees, putting fees at risk, having a pretty aggressive timeline, because this is not our first round to talk about it. Like, this has been a long time.
I want to second what all of us have agreed. I'm hearing all of us have agreed to the importance of elevating behavioral health access to the point where it definitely should be within a structure of a performance guarantee as something that advances the care being provided. My only concern is that this is round one of us hearing about what the standards are. You heard from me significant concerns about what some of them are, and we haven't heard feedback from our health plan partners. And the proposal here suggests that 2024 is the baseline year, and we haven't even agreed to what the standards are going to be. So for me, what is aggressive would be to, and I also will fight like hell to get any more performance guarantees that our board does not understand completely, because from my personal opinion, we made a terrible mistake with the trend guarantee, and I think that was almost put me to the point of resigning from this board, because it took it was so poorly thought out. So every single performance guarantee, at least for OEB, has to be approved by the board as long as I'm chair. Now, that's not for much longer, so the next regime may let it go. But this is round one. This is the introduction. From my perspective, we need to sit down and understand these. We have to come up with the best ones. We have to understand what the health plans are going to be required to do in regards to what CMS is going to be required versus what Mercer thinks is a good idea. And it's not that I'm not respecting Mercer, but in terms of if we're going to require health plans to do things, if we can have it in harmony with what they're going to be required to do, and it gets to the concerns that we have, that's win-win, versus adding to the cost structure by having them have to do things that they're not required in other settings. And we don't know that yet. So I view this as an excellent opening set. The idea of us requiring reporting only in 2024, which ends September 30th, 2024. So, you know, 6 months from now, and we haven't even agreed what they're going to be doing is impossible. So aggressive from my perspective is over the next 3 to 5 months, we nail down what the guarantees are going to do. We work through with our health plans where they figure out how they're going to measure it. That next year is the report only / baseline, and then the year after that, if we want to go fully into the penalty piece, I'm fine with that. So you know, keep 2026 as it is, but from my perspective, it's impossible and probably irresponsible. It's at least irresponsible, but maybe impossible to have those to have 2024 as a baseline when we haven't even figured out what they're going to be studying. Comment.
This is James here. Sorry, there's a little background noise. I hope it doesn't affect. I just wanted to say a couple things, sort of going up a level. One, the things we focus on tend to improve. And I think this general direction needs to just have good, solid reinforcement that this is an area that the boards might want to focus on. Second thing, just to say it again, this is 5% of admin fees. So it is not small potatoes, but it is not 5% of healthcare costs. And then lastly, I think putting some effort in to start the engines of measurement will have its own sorts of rewards. I guess what I mean is getting it measured, the report only is a pretty big lift, a pretty big start. And then if we keep the focus on it, now we know where we are and we try to get better. So some of these performance standards or fees at risk could be for improvement as opposed to perfection. Anyway, I guess I think the direction's solid. The details might need a little refinement, but it looks pretty good to me.
I mean, we definitely need that refinement, and we need to get to a point where we agree to what the standards are going to be, understand what CMS is, and at least for OEBB, we need to get the board to approve them before we move forward. I don't know how we do that, and then also come up with the infrastructure to do the reporting that would be able to look at what happened from October 1st, 2023 through September 30th, 2024. We're halfway through that already. We haven't even finalized what things are going to be.
So Tom, the reports are kind of snapshots, so it wouldn't necessarily be as, you know, over the entire time. But you know, it does take time for the secret shopper, and we do admit it. I mean, and it does cost money, but we feel like it's important. And whether it's 24 or 25, that I mean, but it's just it is, again, we're trying to.
I agree with everything. I agree with everything that that the direction of this. I agree with the we need to get it right, and we don't have we, I just think I think the, having, if the idea is to have a baseline year, we don't have a baseline year. We would have 2 months by the time we figured out what the actual measures are going to be, maybe 3 months at best. And we don't have the infrastructure for doing the measurement. So let's do it right. Margaret, you had a hand up.
Yeah, I just want to chime in and just kind of clarify in terms of the timeline. So in order to meet our contracting deadlines to have executed contracts ready by September, I know our contracts team really needs to have near final language, including language around PG proposals by early summer. There's a lot of steps associated with DOJ legal review of contracts and all of those various steps that have to take place. So I think what we're proposing at this point, first of all, is we're seeking work group consensus that shifting the 5% of administrative fees from the admin / operational measures to the behavioral health focus is the right direction. And then in the next couple of months, we need to finalize agreement with carriers in terms of what the contract language for next contract year will say around this PG. And so I think, yeah, you're absolutely right. Like the detail and nuance needs additional work, which I think we are definitely slated to do over the next couple of months, but then would aim to, by early summer, have details worked out.
But and who would do that work? Because who would do the details? Because you heard from me, I think a whole section is wrong.
So the detailed nuance negotiation, like currently what happens now on the PGs in terms of the detailed discussion is typically handled by staff and Mercer in conjunction with carriers as part of the contract negotiations.
And that resulted in a, I think, a terrible decision. That's a personal opinion, and you can just ignore me because I'm about to be gone. But my view is that performance guarantees need to be approved by the board. That is a board. That's a board. My view is that's a board level action.
Yeah. The plan is to take it to the board. Right, Margaret? I mean,
well, so we'll have to work offline on timing. I mean, the PEBB board certainly meets all summer long, so we have opportunities during the summer months to engage with the board there. We'll have to look at the OEBB board schedule and determine what our kind of drop dead deadline would be to have that in front of the board before they adjourn for the summer. So I think it's I think it's doable. I just think it's an aggressive timeline. And so we'll have to put some focus, I think, in scope our approach for the initial year in consideration of all of that. I think at the end of the day, though, and I know our carriers appreciate this, we want to have aligned guarantees for PEBB and OEBB. I know it's very challenging for our carriers if we have one requirement in an OEBB contract and a different requirement in a PEBB contract when they are trying to work with us collaboratively as a consolidated staff in administering both of those contracts. So yeah, I mean, duly noted, that means our timeline is certainly aggressive.
I don't see the downside of actually giving our plans 3 to 6 months to come up with a plan to look at this, and then spend a year of actually measuring it, and then the year after that, again, put the full guarantee in place. No reason to do it in a short. I just don't see the downside there. I don't know what I'm missing.
So it doesn't sound like we're at consensus, or we're going to get to consensus today. So, I
haven't. Let me hear from from IWG work group members. There's for sure not consensus with what I'm saying and what Mercer and staff are saying.
Right, right.
I'm interested in hearing from IWG work group members what their thoughts are with 2025, which for OEB is October 1, 2024 through September 30, 2025. So could I have Sean? My proposal is to make 2025 a baseline. I'd like to hear from Kimberly and Robert and Sean, because I may be out to lunch on this. I'll acknowledge that.
I was listening to you and I thought it made sense when you said to go to the 2025 to do the shift because we're into March. But again, I'm not the nuts and bolts person. I'm just that it made sense as far as maybe our carriers.
Okay. Robert, Sean?
So let me see if I understand what the dilemma is, because I don't know if I quite in grasping the challenge clearly. So what I'm understanding is that we have, due to contractual, parlay reasons, we have to have a set of performance guarantee agreements agreed to by, what was it, Margaret? What was it? September? In order to have
June 1.
June 1, in order for DOJ to have time to do all the things, right?
Well, in June 1, early summer. So yeah,
Okay.
so when and that is for OEB specifically. For PEB contracts, we have a little longer. It's mid-fall before we have to have.
But we want them to align. So
yes.
Okay. All right. So and in order to have that contractual language detailed enough to have a contract, we have to have these sort of minutia and details sorted out. So for example, we couldn't have something as vague as 5% of fees at risk will be about behavioral health. There will be 5 of them. And we will sort those out together in the next whatever. They all have to be sorted out exactly correctly for the contract in early summer. Is that correct?
Yes. So I mean,
Okay.
I think the substantive requirements of the guarantee need to be finalized by early summer.
All right. So I do see a downside of waiting. Tom, you don't see a downside. I do. The downside is, from what I've observed over my career, is that the plans are masters of delay, of things that they don't want to do. So they delay. You can't, there's always a reason why you can't do something. You can't this is too hard, this is not aligned. And so you end up well, we'll do it next year. And so then there's sort of there's this basic strategy of dispersion of attention, essentially, that will be perhaps move on to a different topic or just come around to it, which is why we don't kind of pen things down. So in my mind, there is a cost to that. And I'm not saying that cost is over the cost of what you're saying. I'm just saying there is a cost of delay. So in my mind, I would rather give it a go and see where we are in early August and see how far we are from consensus with hearing from the plans. What is realistic? What exactly are they concerned about? Is it the way that that we're currently wording it? Do they have an alternative that's more accurate or just more plausible? and you know, and if we get to early August, or sorry, it's for early summer, and it's like, oh yeah, we're miles apart. Then there, you know, we might reassess. But I wouldn't want to preemptively say like it's impossible. You know, I guess I'd want to like give it a chance to work before we delay another year. That would be my initial reaction.
Okay, well, I'll jump in with my partial lack of understanding. You know, I'm always a big fan of taking the time to get things right. And from what I've seen from these data points, I want to make sure we get the data points right, so we get the reporting right, so then we can enforce the you know, whatever we're going to do based on the reporting. If we can get it done in a shorter time frame, that's fine, but I don't want to have to squeeze something in and then find out that, you know, the pieces of data we were trying to collect for reporting on aren't actually the data points we're going to end up using. So if you know, if we can get a clear view of what we're going to be measuring and how we're going to collect it, and then on top of that, you know, this page that we're seeing right now, how all that ties in, I'm okay with that. But I am concerned about our timeline, you know, for the next few months, especially when, you know, OEB is definitely going to be focusing on renewals, you know, the rates for, you know, our next two sessions.
Okay, so what I heard was, let me see if I understood the work group members' view. You know what mine is. And Kimberly and Robert, I heard you saying that you wanted to make sure we got things right. Sean was also um, wanted to move, see whether or not in a couple months, we were able to get to finalize the proposals, get feedback from the plans to see whether or not it was to get the reporting baseline done by the time to get everything, to be able to do the baseline before the start of the year, that is that penalties could be applied. There is, to answer your first question, Margaret, there is consensus that we move the administrative 5% from our current administrative to behavioral health. There's no question about that. The issue, I think, is how do we get the performance guarantees in place, ready to monitor, and to have it into contract language for a October 1, 2024 start for OEB. And this is where we're out of balance for PEB and OEB, but also I think because it's the fact that it's at IWG, it means that it's important for that we do have census. So it's probable that we want to have for staff and Mercer to work it again, and I don't want to, but I will spend some more time with the group. We need to get the health plan's response to this, because I don't want to be jamming something down, you know, making something that's critically important that we do for years and years in the future, that we do things in a way that makes for bad data or bad decisions. That's my concern. So do we have another IWG scheduled for April?
At this point, we do not. We weren't planning to hold an April meeting, but I think we can take that offline and take a look at the schedule and further discuss.
I think this is everybody is saying this is hugely important. It's more important than us looking at hospital utilization pieces. I know that's important too, but this is something that has been identified by both boards as important. And Sean, I agree with you. We need to move with deliberateness. Is that a word? But I think we have to get it right too. So I'm going to propose that we see whether or not we can get, again, we could have maybe a three-way, a four-way meeting with the plans, Mercer, OEBB-PEBB staff, and I would join you, and pardon me, and any of the other IWG members. When we get this gathering set up, we'll see if you're interested in joining, and see whether or not we can come back with a proposal that, one, meets the needs to understand it, get it right, but also, as Sean said, to move the thing forward. Is there, again, Sean, Robert, and Kimberly, tell me, is that an appropriate next set of steps?
I think that's fair. Yeah. I mean, I think we're on the same page in that, you know, there's some deliberateness. We want to give it a try, and we want to get it right. You know, there's a balance thing here, and there's, you know, the devil's in the details when it comes to metrics. We all feel that. So, you know, I think that's right.
Okay.
Yeah, me too.
Robert.
I agree.
Yeah. Okay.
Okay. We will regroup.
Ali, I think we did find some consensus.
You got consensus. Yeah, that sounds great.
And we'll regroup on timing for that and come up with a plan.
I know it's an awful time.
Oh, it's fine
for all of us. No, it's a
Yeah.
tough time because we have so much other stuff going on. As Robert talked about, our main focus is trying to get through the contract.
At least it's not a long legislative session, or we'd really be under the gun, you know. So
just good
so
point. That's
absolutely
glass
look at how
half
much
full,
extra
Sean. I
time you
love it.
have now,
Yes.
Ali and Margaret, right?
Okay.
Exactly. Yes.
Okay.
Oodles. No, appreciate the glass half full perspective there. And so we're overdue for a break, Tom. Looking back at the agenda. So I will let you kind of decide in conjunction with the work group how you'd like to handle things.
I would like to, we need a physiologic stand up, move around, take deep breaths, get a glass of water and pee. So we will meet again in 7 minutes at 3:15. Alrighty? See y'all at 3:15. Okay, it is 3:15. I would love to have Sean, Robert, and Kimberly show your faces. That way I know that you're there. There's Sean. I see Kimberly. Are you there, Robert? I'll give Robert another minute, and then we'll get started. Are you on, Robert? I see. Well, I don't see your face, so I can't tell. Okay, 3:16, we got to get started. So, Margaret, go ahead and introduce our next section if you could.
Yes, absolutely. Thanks so much, Rose. Yeah, so on our next topic, we are on to attachment 4. This has been pulled together by James and Emery and other folks on the Mercer team. It relates to some work and analyses that they've been doing over a period of time here, just looking sort of at a high level at OEB and PEBB hospital costs and utilization. This is intended to be an informational report for the work group. I think the hope is that it will spur some good discussion. The Mercer team is certainly going to share kind of any key observations they've noted thus far, but ask questions. And I think we certainly anticipate that we may identify some additional follow-up work generated by this particular report. So with that said, I will pass it over to Emery. Emery, thanks so much. You're covering a lot of bases today, so I appreciate it. I know you've had quite a morning and it's been a busy afternoon too.
Yes, it's been a fun day. James, I believe, is still on, so I think I will count on him to help provide some commentary. But this is a hospital payment cap monitoring report, and let's move to the next slide. So we're going to go over some things. I know we are limited for time, so we probably won't get through most of it. But let's move on. Just to kind of lay out some of the data that we're looking at. So this report's been a little bit delayed. It's actually going to be theoretically for calendar year or plan year 22. So that would be calendar year for PEBB, and on the 10 October to September basis for OEB. And then we do have 23 information. So it's actually a full year for OEB, but partial year for PEBB. We do use incur data, and it's from the data warehouse, where we kind of try to match up claims to different facilities, as well as different groupings, to kind of tease out what's happening, at least for the overall cost for OEB and PEBB in this case. Next slide, please. Just note on the DRG, this is kind of like a historical thing that was found in the past. The DRGs don't necessarily match up exactly to the DRGs that are paid for, so there might be some mismatches in this case. But it's just something to be aware of. I don't think it's a huge issue, at least for this report, but it was an issue in the past. Okay, next slide. So some key findings on here. So overall, cost per admit at capped facilities there on the left did increase by about 6.8% from 21 to 22. So capped facilities are those facilities, I think it's 24, if I remember correctly. I may have got that number wrong, but certain facilities that are DRG facilities in key, actually in areas that, essentially metropolitan areas, that are not children's hospitals, essentially, or VAs. But these facilities are capped at the 200% Medicare for inpatient and outpatient services, and their cost increases per admit did increase by about 6.8% in this case. The outpatient services did increase by even more, 8% at capped and uncapped facilities, and the cost per outpatient but the cost per outpatient service is lower at capped facilities than uncapped. That is, potentially a higher number than I think we all wanted to see, especially compared to that 3.4% limitation. One of the issues or potential reasons for that is that final bullet in that emerging issues section. So the CMS market basket trend, essentially the underlying unit cost that facilities get paid. In fourth quarter of 22, that cost increase was 6%. I think historically it's been below 3%. We do show a graph, but the cost trend has been higher, and that probably because it's tied, a lot of contracts are tied exactly to 200% Medicare. Increases in the CMS payments ends up increasing PEB and OEBS payments. And in this case, it's not the panacea that's keeping it down below 3.4% in this case. And also, some facilities, some services that are currently contracted, at least commercially, below 200% of Medicare, we are seeing increased costs in those services. Again, newborn DRG, so a lot of maternity where maternity costs have been lower. And while there was that revision that helped with the initial surge in prices, we are seeing more movement for those closer to the 200% cap. And also some other services like laparoscopic and other patient services like colonoscopies. We do have a slide kind of showing some of the differences in pricing. It's where ASC, Medicare ASC pricing is actually significantly lower than outpatient. And so site of service might be one area, one way to help combat some of this, where maybe members are directed to lower cost settings. Another way would be to potentially implement something similar to what was done by OEB, where you set a reference-based price. So we're not going to pay more than X amount for service. And so that might help counter some of these actions that we're seeing in the marketplace. They do have member impacts. And so, each board's going to have to consider that. But in order to maybe manage costs, the unit costs, there are potentially ways to kind of shift to lower unit cost places that might be just as efficacious and help the member and PEB and OEB save money in this case. So those are some emerging issues that we'll discuss a little bit more in the other slides. Some next steps there on the right, follow-up questions, discussions on that, talk to the plans on the contracting and just seeing on the 20% Medicare impact of CMS, rate increase and stuff like that. And again, the lower cost potential settings as a possibility, which was brought up in the PEB board meeting as an option by MODA as well. So, continue to work on that. But before I move on, any comments or thoughts on this key quick recap?
I guess I have a couple of questions.
My only point. Oh, go ahead, Sean. I'm sorry.
So first, I think I saw an article the other day about a national study that sort of looked at our little experiment here and concluded that it has saved money over time. That I guess my only comment to that is originally this committee, we had invited some legislative partners just to be a part of, because this was a legislative driven initiative, this cap. It wasn't, that's where it happened. So I wonder, I guess this is a question, I wonder if there's an opportunity or if someone's already shared that with Representative Nose, who's on the PEB board, or someone in the vicinity, just for he was around when it was passed. He was part of the original legislative intent. So it's just they don't often get feedback on their own legislation about how it went. They just kind of keep going, right? So there's that. And then second, when it did pass, I recall that we predicted that we might have challenges around a couple of areas. And one of them was other costs are maybe going to go up to 200% because they want to compensate. And then we also predicted maybe they're going to places that are currently not under the cap, they might shift work over there and then raise those prices because they're not capped. So, and then that CMS might actually raise beyond 3.4%. And then what? And so that's exactly what we're looking at now. And that's what so that's also a legislative discussion, because this is all coming because of a legislative intent. And also, yes, we should probably discuss next steps that we might be able to adjust on our side that kind of like compensates. I'm not just running to the legislature every time we need something adjusted, but it's at least opening the door for a conversation is all I'm saying. That's all.
And to your first point about the report, we do have a couple slides about it later on. So we will talk a little bit about it, but we can definitely highlight it. But yeah, definitely. Ali, I think Tom was going to say something.
Oh,
Or
I was, Sean said what I was going to do, and my only additional comment to Ali is this finding needs to be added on to our discussion with the governor's office in terms of legislative intent for the next legislative session.
yeah, definitely. And I just want to mention the story was shared with Rep. Nose, and in fact, our new director at OHA, Dr. Hati, picked up on it too, and she asked Margaret and I to work with the communications office to broadcast it out, through OHA channels. So yeah, it's getting a lot of play.
Good.
Thank you. Appreciate that update. Okay, moving on. So just wanted to list the hospital payment rules, the ones effective initially, and then the revisions are on the next slide. So we can move to next slide. Yeah, so the revisions here to kind of deal initially with that billed versus submitted and charged, allowed, maximum allowed, which did help, and it was noted in the report that's being referenced. But this is the language. Next slide, please. And then to a couple of slides on that health affairs article on the hospital cap that was just being referenced. So in terms of a couple of the key findings, Exhibit 1 basically said, yeah, there were savings. But, the first implementation, you can see the dotted line for first cap implementation, at least for the inpatient costs, they didn't drop down significantly until after the second cap. And that's because of some of those 200% services, newborns, maternity care, I think was the biggest one. There are a few others as well, where the cost went up and they paid, submitted amounts were paid versus what was contracted. And as a result, there weren't the savings achieved in the inpatient that we had all expected and hoped would happen. But for the outpatient, which is down below, you can see that the savings did happen after the cap. That the percent of Medicare was definitely higher, and so overall savings are there. The other interesting finding, I'm not sure what's to note of this, but if you take a look, the control enrollees versus state enrollees, control enrollees were below in terms of the inpatient and outpatient services, and now it's states matching the control enrollees, which it's good that the state's not paying more. OEBB-PEBB's not paying more, but the fact that it was higher, at least in this study, was interesting to me. I wasn't aware of such a big gap, actually. So I'm interested to find out more about that, but that was interesting to me. Next slide. And this is the other issue where I think, is tied into that increasing rates. So this showed that, there were facilities that were above 200%. The findings are on the left, 13 facilities were above the 200%, and then they dropped down. However, this 11 hospitals below, they increased towards the cap for 6 of those facilities. And that's really where I think, we want to be extra aware of. It's not just, I mean, that's just, I guess, a macrocosm of the issue. There's definitely some services that are below the 200%, and keeping an eye on those is important, and to make sure it's not increasing disproportionately. And I think we've had discussions about this, especially in renewals, the fact that some hospitals, the plans contracted at 200% across the board, even if the hospital was below 200%. And, we heard that, it's, I guess it got borne out in this study on the CAP as well. And so, that's unfortunate. Hopefully we can try to rectify the situation. But if you want more, go to the report. It's out there, and we show the link there on the bottom left. Okay, next slide. This is the just kind of graphically that CMS market basket that we had talked about, and as you can see, that peak in Q4 22. Forecast for 23 is still above that 4%, which is up obviously above the 3.4% limitation in the straight line. So unfortunately, these are the things that we're dealing with right now, where the cost for 22 increased. We're seeing higher cost increases for 23 as well, and that's carrying forward into our renewals. And to, unfortunately, at least for PEBB, talking about ways to have to reduce costs to meet that 3.4%. So while CMS, while tying to Medicare helped save money in 2020, 21, and 22, towards the end of 22, unfortunately, the increases were a lot higher. I mean, I don't think it's drastically different from what we see across the healthcare market, but it did not cap costs at that 3.4%. Okay, next slide, please. Taking a look at the inpatient results. So we do show 23 there on a year-to-date basis for PEBB, but full year for OEB. So you can see combined OEB and PEBB, capped, uncapped, in terms of inpatient admits. Overall, the cost per admit's about the same on average, which is okay. That's I guess. There are definitely different DRGs mixed in there, so I wouldn't put too much into that until we look at actual DRGs, but it's a similar cost. But the change over 22 is a little bit different, where PEBB's cost actually dropped a little bit compared to OEB, and overall it's been pretty flat. The capped and uncapped facilities change was flat for 23 over 22 in Oregon, but in Washington, Idaho, the cost increases were higher. Fortunately, there weren't as many admits. Most of them are in Oregon. But comparing for 22, you can see that capped hospital increase there in the top right-hand corner, where the increase was 6.8%. That did moderate a bit again for 23, but that increase happened in 22, which ties into the CMS increases. And then for OEB and PEBB, overall increase was 3%, although PEBB increased by more than OEB. So for 22, cost did increase pretty close to the limitation, at least for admits. The cost per admit, number of admits, differs based on different situations. But overall costs, at least for capped, it's not keeping it at the 3.4%, because I guess CMS, Medicare wasn't at the 3.4% for 22. Okay, next slide. Taking a look at the top DRGs by cap, and this is where we start seeing some of those things where, okay, where are the costs increasing consistently? And so if you take a look at some of these, and these are in order of total allowed for OEB and PEBB. So these are the most impactful DRGs. As you might expect, deliveries. Deliveries of newborns are pretty much some of the biggest services. And if you take a look at the change from 22, as well as change from 21, so the top two, vaginal delivery and C-sections, those increases for 22 continue to rise. And so this is where we're talking about, maybe the costs are below 200% of Medicare because commercial is Medicare does not have maybe an appropriate pricing for these DRGs, and the facilities are potentially finding ways to increase that. And the increase in 22 is definitely higher than 21 in this case. The normal newborn is down below 795, so it's 2/3. That increased 14.5% in 22 and is another 4% in 23. Neonates with significant problems, 794 towards the bottom, kind of a similar story, but bigger in this case. So those are some of the bigger ones that have been seeing increases over the 2 years. The C-section at the very bottom hasn't seen that big of a rise, at least for 23. But some overall, the maternity cases, again, those are where the costs are rising. Those are where we know the costs are below the 200%, and the hospitals have room to move. And unfortunately, it's eroding away some of those savings that we're seeing as part of Senate Bill 1067. Okay, next slide, please. Taking a look at the uncapped, there's definitely a lot more movement here because it's total allowed. So some of the things like the 790, it's just bad data, just data issues there with the big increases or decreases. But again, I guess similar story with the top two, where the cost per DRG is increasing across the board. These are uncapped, but you're also seeing consistent increases there. And then neonates down below, and vaginal deliveries, again, bigger increases. So this is where we're, highlighting for the most part, the maternity costs continue to rise. And they're rising, higher than the 3.4% limitation. They are a significant number of services. I mean, for PEBB alone is 3,000, and I think OEBB is probably, similar as well. So we are talking about a lot of admits for these services that are seeing some of the bigger increases.
We have any initial gut reaction about why those costs are going up? Is there some kind of new innovation procedure, this or that, new drugs, something that's going on with births or what? Yeah. Increased age of maternity age, what's anything?
I don't think so. That's something that we'll want to work on for sure with the plans to take a look and dive a little bit more into the data by those subsets, cohorts. We did, is it 2 slides down? Actually, let's move a couple. Oh, you just passed it. Go back one. So it's we just want to kind of illustrate the issue here. We don't know. I mean, it's something that we want to look at. So you can take a look at these two charts, one on the left, one on the right. So the one on the left, delivering newborn. So it's certain, it's a certain facility that we blinded, but you can see the costs. They do, average cost is kind of random by month, but on average, it's kind of small increases prior to 2020. And then 2020, Bill 1067 should have capped it, but they charge a lot more. And then the revision came in, but then you can see the costs continuing to rise there. And so, I don't know what's really underlying it, other than, we're looking at some of the submitted charges and stuff. And James was working on some of the charge masters to see what he could see in there. I don't know if it's any of the stuff that you mentioned, Sean, versus contracting issues. So over there on the right, cardiovascular procedures are at the 200%. Or essentially, you can see it was pretty flat pre the bill, and got capped and came down and been pretty consistent. So, right now, correlation, causation, I don't know. Maybe it's just contracting, but that's one of the things that we want to look at. James,
Okay.
Is there something you want to add?
Well, I think it is not surprising that for the DRGs where the cap is not in effect, there's going to be upward price pressure. And I think it comes down to how strong the different parties are in different positions for the negotiations around contracted rates. I did look at the billed charges as well as the allowed, and the billed charges data isn't quite as good in the data warehouse, but you do see the thing that happened in 2020 quite clearly, especially on PEBB, where the allowed was above billed, which was the problem that we attempted to correct. That has been corrected, but I think probably the short story is the billed charges are trending up, meaning that minimum of what you bill versus your contracted rate, the what you bill is going up. So the prices and the alloweds are going up. So I just thought this was interesting to look for in the data. Again, I think the plans will have a lot more granular understanding about those contract negotiations with the hospitals, but where the cap is meaningful on the right, it makes a big difference. And where it is not yet meaningful, it's, still getting there.
Well, I look forward to hearing more data, about it, because this is exactly what we were worried about. And I feel like Providence is kind of an interesting case study. Not to specifically pick on them per se, but it's interesting because they have their own network, which theoretically they have more control over, because it's theirs. And then they also contract with hospital system like outside of there, right? And so theoretically they would get better prices internally. At least that's what they say. They should get better prices internally. So it would be interesting to compare, right? And like, is there upward pressure on both, or like, yeah, like what's happening? Because what you just said, James, is like it's just like the negotiating power. Theoretically, Providence is negotiating on our behalf with themselves. You know what I mean? Like we're purchasing access to their own network. So that would be an interesting comparison. To sort of peel apart why, and what are we going to do about it?
Yeah, I think in the end, the legislation had a bit of a blind spot around maternity costs and Medicare's payment levels, and I don't know what we would have done differently had we had perfect foresight. But there are a lot of people in the system who are trying to maximize revenues, and there's a way to do it.
Yep. And I guess for more fun, we can turn to the outpatient services. Let's move a couple slides. So some of the observations, a little bit more detail on the facility outpatient. So I mentioned earlier, allowed per service did increase by 8% for both capped and uncapped. Total procedures didn't change much. And then the bottom one, I think, talked at least, the ER visits are increasing post-COVID, and not necessarily the most efficient place of service, but those services are increasing in this case. Capped for OEBB-PEBB, the switching between capped and uncapped hasn't really been happening. So people are kind of staying and using services where they have been historically. But the allowed per service at capped facilities for PEBB increased quite a bit more, but that's some of it's, I think, just service mix in that case. And then the cost in Washington, Idaho, we're seeing consistent increases for OEP and PEBB. So as with the inpatient services, cost per service seems to be increasing outside of Oregon. So in some cases, yeah, maybe the cap's working in that there, but we're seeing upward cost trends outside of Oregon. Some information on ER, and then specialty drugs via J codes there. The J code data is seems a little, to use an actuarial term, wonky. So I don't know how much we can draw from that. So we won't really go over that in too much detail. But with the outpatient services, I think there's some cited some services that are below the 200%. Kind of almost more commodity services that we're seeing higher cost increases. For example, colonoscopies or laparoscopic surgeries, where compared to Medicare, that maybe the payments are lower than 200% Medicare, and then those costs are increasing more. And one other area that could be switching is to moving to ASCs, where the percent of Medicare payments are definitely lower. And so even if ASCs are paying at 250 of Medicare, the overall cost is lower. But we do have a slide on that coming up. Next slide, please.
Emery,
Yes.
you have about another 8 minutes, and then we're
8
going to
minutes?
wrap
Okay.
up.
All right, so I might be able to get through a couple slides then.
Okay.
So increases, this is compared 22 versus 21 in terms of the cost per service. Again, as mentioned before, about 8% increases for capped and uncapped. And then you can see the ER visits increasing by double digits across the board. So that's some of the increases. And then the Washington, Idaho hospital cost per service increasing quite a bit more than Oregon. Next slide, please.
Are births going up?
Sorry?
Or births, you know, and like
No,
that's
those
what
would be it.
maternity visits in the ER. I mean, that's what we're talking about. Is it up?
Maternity birth in the ER. I don't think I have that data. I think you get admitted at that point, so you wouldn't be in the ER visit.
Yeah.
Okay. Yeah. But I think the mix of services in the ER, if you take a look at level 4 and 5, higher intensity, those are dropping. It's level 3, 2, and 3 that services are increasing. So not as intense. So people are using the ER more for services that aren't maybe deemed as severe.
Like a higher proportion
Yes.
of low intensity.
Yes. Higher
Not to
proportion
say
lower.
that the high intensities are down, just that there's more
lower intensity services happening. Yeah. That's, I think, where the growth is happening. So you can see this third line, the 99283. So that's level 3. The increase from 22 versus 21, 21%, almost 22% more of those visits. And so the cost per visit is only $471, at least for that procedure code, but you're just getting a lot more people going in for something. $471 is still a lot more than an office visit or urgent care visit, and those services might be better seen there or via telemedicine. But some of the other increases, I think, where we're seeing the bigger change, 22 over 21. So row 6, I think the laparoscopic hysterectomies, 17.3% increases. Appendectomies is down lower towards the bottom. That's increasing 5-6%. And then you got the colosex, I can't pronounce it. I'm just not going to. It's 18.8%. And then colonoscopies, those services are increasing quite a bit more. Cost has only increased 3.5%. And then the one below it, 4.2%. But there are definitely lower cost settings than in an outpatient facility, for example, an ASC. So those are some of, actually, let's move on to the next slide. Uncapped, again, showing some of that information with the ER visits there at row 3. Again, lower acuity ER visits are increasing more than the higher level acuity visits. The costs, if you compare them, these are, the cost increases are higher, as well as the allowed per service. And then if you could compare some of the other services, I won't do it here, but if you flip back and forth between the two pages, you can see the difference in costs, and the outpatient facility uncapped costs are a bit higher in this case. And some of those trends are definitely higher. So without the cap in the outpatient is definitely having more of an impact, but there's definitely cost pressures, and some of the other services that are below the 200% seem like they're increasing a bit more than the typical trends. Next slide. So this is talk in more detail on the laparoscopic and colonoscopies. So to really illustrate the point, so the cap per service, uncapped per service for these 5 services, you can see the difference in pricing. And yeah, go ahead.
Can I interrupt you for a second? I know you're almost out of time. Can you go back
Oh, sure.
to the slide previous? Do you know, do the plans have a strategy? Like, have you discussed with them, like, what are their thoughts around this low level medical decision making dramatic increase? Like, do they must notice this, like, and on our behalf, they're like trying to active manage, right? So they're like, oh yeah, that's not good. So like, do they have a plan? Do they know, like, do they have strategies? I mean, this was a problem before the pandemic, right?
Yes.
Like everyone was trying to figure out, like, you got to stop people doing like a case study, like a sample, a case study. Who are, like, what's happening? Why do they end up in the ER? Anything like that with our plans or any of them?
We so, and I'm gonna put this on PEB because I know, because I work on PEB. On the renewals, I know we asked them about this. So, I mean, it's one of the questions that we asked them. It's like, what are you
Mhm.
doing to deal with utilization? And we had a phone call where I specifically brought up, hey, are you with one of the plans, are you managing this
Right,
to make sure
right,
that you're driving people to the most efficient levels of care? Because we're seeing bigger increases. So based
right,
on all of the utilization reporting I've provided to you, in the PEB meetings, this is, I think, a same story that I've been saying over the last few years. ER is increasing, ER is increasing. And we've asked, there's been some payment optimizers, but I don't know. I mean, it's like, yeah, it's a question, are you utilizing services in the most effective manner? And, we've asked that question, and I don't know if there's been a good answer, in my opinion.
okay, all right, thank you.
Next, let's go to the next slide. So I'll make this my last slide
You've
because I
got
have 3
2
minutes.
minutes.
Yeah.
Yeah,
Okay. So
great.
just trying to illustrate the site of care and the potential savings. I mean, these are, again, some of the surgeries that you saw in or outpatient services that you saw in the last couple of slides. So you can see the different capped facilities, capped per service, uncapped per service, and you can see that capped in the most cases, all but one is actually lower cost than the uncapped. The one at the top is basically the same on average. But when we compare it to the 100% Medicare for outpatient facility, you can see that generally these are below the 200% threshold. Um, but we're seeing cost increases for 22 and 23 for these services. And so there's room to move on this. So there's maybe the facilities are moving on it like they are on the maternity services. But the column to the right, if you go to an ASC, ambulatory surgical center, look at the pricing difference for 100% of Medicare versus the outpatient facility. There's a huge difference. And so driving people to these cheaper locations for these services um, would potentially save money because these are more highly utilized services for OEB and PEP. And so what can be done here if we can't get the contracting under order is to potentially move people to lower cost settings or to set reference-based prices like OEB did for knees and bariatric surgeries, those services where it's like, hey, really you shouldn't be paying more than this point. We're not going to pay more than this. If you're going to be more than this, then maybe we don't contract with you, or we're not going to I think that worked, at least from what I heard with OEB, where all the facilities dropped down to the reference-based price. But just that might be more pressure. It's just a suggestion, but somehow switching services to lower cost settings, whether it's, plan design using advocacy, or, trying to get the provider to do that. I mean, this is kind of like COEs, right? I mean, but for other services as well. And with that, I will pause with my 1 minute left to see if there's any other questions before I turn it back over to Tom.
Huge amount of data, Emery, and it shows the complexity of following because 1,000 different widgets that are happening and trying. Then I think the main takeaway for me is the is the blip that we saw in the CMS trend. What that graph shows is it dropping under 3.4, but that's all forecast. So we cross our fingers and our toes that your forecast is accurate. And to talk to the issue that Sean just raised in regards to like changes in ER, what you don't see, Sean, was what the utilization was in 2019, then 2020, then 2021, and 2022. Because what may have happened is 21 still may have been in a huge trough that was associated with the pandemic. So it's pandemic kind of threw all of our year-to-year observations into a mixer, and you really need to look at multi-year utilization factors to understand whether or not that jump was actually something that was just reverting to the mean. And I don't remember the specifics of that, but we could sure it's an area that of us looking and talking to our health plans to review the utilization data to see if that was actually part of it. Okay, we are within 4 minutes of the bewitching hour. Rose, do we have any public comment?
No, you have no public comment.
Okay, so let's do some summarizing. What we, and I apologize that we didn't have time, Emery, to get through your entire presentation. I think you really did show, though, in your limited amount of time, really at least many of the important points. The differences between capped and uncapped and outpatient, and so the focus, the challenge that we had with CMS's jump in 2022 trend, that is, and then looking at site of care has to be an ongoing concern that we work again towards. And in terms of follow-up on the behavioral health measures, Margaret, do you think you can summarize what our next steps is, or do you want me to try?
I can certainly take a stab at it. So I think in terms of next steps, certainly hearing that we need to continue to proceed in this direction of shifting the 5% of fees at risk onto the behavioral health focus area. I think we as staff in Mercer can go back, given some of the conversation that was had today, and take another look at how we would propose a potential rollout of that. Currently, we were not planning. Our scheduled meeting date in April would be Tuesday, April 16th. We were not planning on holding an April meeting, but I think we need to probably debrief a little bit and figure out timing. I'm not kind of give a sense of if we think we can have all of that ready by April 16th, it might make sense to bring it back to that established meeting time. I think once we debrief as a team, we'll probably be able to circle back to the work group members and let you know our thoughts on the timing for that.
Yeah. When is the May meeting scheduled for?
The May meeting would be, I believe it is, let me see, it would be May 21st. That is the third Tuesday.
Yeah, okay. Okay. So we will, I would like, and the other part is to, I understand the Mercer and OEBB-PEBB staff have to debrief. The additional steps that I would like to see is the response from the plans, and I would like to see the specific set of standards that CMS is going to be requiring for the health plans in the very near future. I think that would be also something we should see whether or not that set that that the plans are going to have to do no matter what, how close that gets us to where we want to be. And then we can talk about what we need to add to it. And also the
Okay.
timing for when CMS is going to be requiring reporting.
Okay,
Those
certainly,
would be,
that will
those would be
certainly,
helpful.
certainly we can definitely include that as part of the follow-up. And I guess I will just say, Tom, I was going to extend a huge thanks to you for serving as a work group chair and for being
For-
such an engaged member.
For being a pain in the ass.
Engaged member. No, a very engaged member. Lots of good comments and thoughts to share. Very engaged over the past several years. And I was going to note that this is your, or was potentially your last work group meeting. But now that we might be having a meeting in April, it sounds like you might not quite be off the hook yet. So we will see. We'll firm up that timing, and I'll get some communication out to the work group so that you all know what to expect for your calendars.
Perfect. Great. Thank you so much.
Wonderful. Thanks,
it is
everyone.
We're 4:01. We're a minute over. Sorry. Bye-bye.
See y'all.